keynote speakers on this 5th Global Conference on Addiction Medicine, Behavioral Health, and Psychology. Funding for 2 of my studies came from PCOM Division of Research and also the Organic Remedies Corporation. Briefly, what I'm going to talk about is some clinical pharmacology of THC, the investigations I'm doing at PCOM, and also a combined THC CBD study at Organic Remedies dispensaries in Pennsylvania, which are in Pennsylvania, Paoli, York, and South Pittsburgh. So one of the things that, let me just move this out of the way, in terms of worldwide developments, February a couple months ago, that the worldwide cannabis market will probably be around 61 million in 2024, projected to be 123 billion by 2028. This is just, I know it's a busy slide, but in any event, it just shows you some of the individuals in treatment for cannabis issues. And again, you will have the slides, so I don't need to run through it, but it's widespread in most countries. So one of the areas of focus is chronic pain, which we know is disabling, which we know is costly, and it's very common. So in the US, about 50 million adults have chronic pain either daily or on most days. And about 1/5 of ambulatory primary care and those who go into specialties have chronic pain. So it's a pretty big deal. Researchers at Michigan Medicine did a survey from around the country, not all the states, but 36. It's pretty impressive. And what they found was about 1/3 of those are using medical marijuana for their chronic pain. As most of you probably know, but if you don't, it still is illegal in the United States federally. But within each state, there are various programs to allow medical marijuana to be used. Another report shows changes in individuals who are using cannabis, and you can see that there are decreases in prescription opioids, non-prescription, and OTC products. So in other words, those who are using cannabis have had a decrease in the use of several different types of meds for their pain. So there's no doubt that there is efficacy. The term suicide is mine. If you look it up on the internet, my paper should come up at the top or near the top. Because of my work, I know that, and I've had several patients who really were suicidal based on their pain. They can't sleep, they can't eat, their life is just awful. So I thought about teratogen, which some of you may know causes birth defects, carcinogen, which I'm sure everybody knows. And what about something that causes a person to want to commit suicide? And when I looked it up in our library decades ago, it wasn't there. So that's my term, anything that causes a person to think about committing suicide. And in my clinical role, poor pain management is definitely a suicidogen. And there's my citation. So in terms of yearly deaths, comparatively, tobacco, again, this is in the US, is, you can see that number, 500,000. In my opinion, tobacco should be off the market. There is no therapeutic benefit, only toxicity. Second are the opioids, which are now over 100,000 in the US. That's an issue. I could spend another separate presentation on that. As I tell my medical students, fentanyl, clinical pharmacology, fentanyl is a good drug. The question is why so many individuals feel that they need to take a drug. And again, a lot of people in this conference are dealing with addiction. So we know there's an addiction issue. But in any event, in terms of OD, we have that. In terms of marijuana, we don't. We have no recorded deaths of an overdose from marijuana. So why is that? Well, in terms of opioids, they depress the brainstem respiratory center. Marijuana does not. So we believe that that's the most important difference as to why we don't see any overdoses causing death of marijuana. Another study, Annals of Internal Medicine, using opioids to manage chronic pain. And this came from the United States Veterans Administration and the Defense Departments. It's a practice guideline. And they're talking about not using opioids daily for treating chronic pain. And the conclusion from this large study is that the opioids provide a benefit that are outweighed by the risk to the patient compared to the good information or the good outcome. So small outcome of positivity, larger outcome of risk to the patient. And their conclusion is if you really need an opioid, buprenorphine is the one that should be given because it does have a risk profile that's lower. I think everybody knows the answer to this, and this becomes an issue with marijuana. So we know it's obviously a serious psychological condition, and a number of things that individuals get addicted to, and I'll just let you read that list for a moment. The bottom line is one can get addicted to anything, including marijuana. In terms of further support from the NIDA, which is the National Institute of Drug Abuse in the US, the quote there, most people who use marijuana do not, and that's my emphasis, do not go on to use harder substances. And again, NIDA, National Institute on Drug Abuse, says alcohol and nicotine, like marijuana, prepare the person for use of harder drugs. So alcohol, nicotine, and cigarettes, not just marijuana, prepare somebody to move on to harder drugs. So it's not just that, well, you smoke marijuana today, tomorrow you're shooting heroin. For some people, that is a progression. For most, it's not. Just like most people who get opioids for treatment, most people who get opioids for treatment do not go on to have an opioid addiction problem. Physical dependence, again, pretty much everybody knows that, but for me, because I'm going to make some points about marijuana, it's a biological condition and it's homeostasis, the body's adjusting. And for example, with caffeine, as I tell the medical students, get up on Saturday morning and have no coffee. And I hear the groans from the class because the body with the stimulant adjusts by reducing brain activity. So you get to the point where if you don't have it in the morning, you really feel sluggish. Obviously, opioids cause the same thing. However, it's not driven like it is in a person who is using it to get high. Person who's using it to get high keeps pushing the dose and pushing the dose. So physical dependence occurs to a much greater degree than a cancer patient. Okay, so now we're looking at specifically marijuana. The molecular structures are very similar. Cannabidiol, I pointed out with the arrows, where there are some slight differences compared to tetrahydrocannabinol, but there are some differences in overall use, and for sure, one of the most prominent is CBD does not have any major psychoactive properties like THC. Been farmed for thousands and thousands of years. Over 500 chemicals are in the sativa, and over 100 are known as cannabinoids. So 3 of them that are most prominent are CBD, delta-9, tetrahydrocannabinol, and also delta-8 tetrahydrocannabinol. And it's interesting, in the United States, most laws are against delta-9, but there is no laws right now against delta-8. And that delta-8 is really, from all practical clinical pharmacologic levels, delta-8 produces the same clinical profile as delta-9. Delta-8, same clinical profile as delta-9, except it's less powerful. In terms of brain function, anandamide is the brain chemical, and obviously it's going to have a receptor to fit that endogenous molecule. Well, here's THC. And you can see the molecular structure of THC is similar to anandamide, which is why there is a similarity in the endocannabinoid system, which I will get into shortly. CB1 receptors mostly up in the CNS, and CB2 are mostly in the peripheral nervous system. Where are they in the CNS? Well, they're in the cortex, they're in the hypothalamus, the hippocampus, spinal cord and medulla, cerebellum, and basal ganglia. At the receptor level, and you follow the red arrows, the normal inhibition of neurotransmitter release ultimately is what happens. But item number one, you have release of neurotransmitter. Item number two, action number two, it hits the receptor. Item number three, there is a signaling. This is the endogenous CB1 ligand. Goes back to the presynaptic CB1 receptor. Item four, it activates a G protein, leading to the reduction in release of the neurotransmitter. And nabilone is thought to activate those receptors directly, which again acts like an endocannabinoid. So there is information about how this very unusual compound acts in our system. Again, a busy slide. Again, you will have my slides, but this is the endocannabinoid system. It affects, it's almost like acetylcholine, a neurotransmitter. It affects many, many organs and systems of the body. And again, you will have this in my slide. You'll be given my slide pack. My niece sent this to me and said, "You probably won't use this, Uncle Fred." I said, "Yeah, I'm going to, because you can't spell healthcare without THC. And of course, the point is there's THC in the middle." So in the United States, we have cannabidiol, which is used in treatment of seizures. We also have delta-9 THC, and it's used for two purposes. One, to reduce chemotherapy chemotherapy-induced nausea, vomiting caused by chemo. And also in patients who are cachectic, who are not eating because of like AIDS, then it can stimulate the appetite. So again, there are several compounds out there, dronabinol and nabilone. Both of them are delta-9 THC. I do not know why. In the United States, dronabinol is a C3, Schedule 3, and nabilone is a C2. Again, it's the same molecule. Makes no real sense. Okay, so in terms of some of the clinical pharmacologic actions, this is a cigarette that's 3.55% THC. In Pennsylvania, one of the states in the US, the limit is 10 nanograms per mil of THC. What does that mean? It means in the state, if you have a level in the blood of that 10 nanograms or higher, you cannot do any work in the state of Pennsylvania. However, if you can look at about 6 minutes, and it'll be on the next slide, the level of THC is up by almost 15 times. So it's something that we all know. Again, these are clinical pharmacologic data. There's nanograms per mil of THC, and again, less than 10 minutes by smoking it. Now, the problem with this and other studies, which is different from mine, is it does give you the percent, but it doesn't give you the dose. And there are a number of studies which I'll refer to that talks about people using chronic marijuana, and they need more pain medication after surgery, but they don't give you the dose. That's where my studies are better in terms of that aspect. Dr. Catherine Lynch produced a very interesting study. What she did was measure blood levels of THC at nanograms per mil and breath levels at picograms per mil. And this is similar to a breathalyzer in alcohol. We know that the amount of alcohol in the breath is much less than the alcohol in the blood. But the point is, as the blood level goes up of alcohol, the breath level goes up. So the breathalyzer for alcohol is an index. Well, this is the same thing that she did for breath, that she found that the breath THC, although smaller, does rise and fall with the breath. So it can be used as a marker without having to stick somebody for a blood sample. Very interesting study. In terms of fraud, one of the things that's interesting is, suppose that you want to just get CBD because you work in a job where you can't have THC in your system. So what this study did was look at the contaminants and the percent of mislabeling. And almost 20% had less than 80% of what was supposed to be in there, less than 4/5 of CBD. Some of them, 40% about, had 120%, but half of the products had THC. So here's an individual buying only CBD, because they can't have THC. And in fact, in this particular study, half the products that they purchased actually contained THC. So the person would show a positive, and in Pennsylvania, they can lose their job. This leads me into adverse effects. My neighbor's pot smoking bothers me. This is from a person who lives in an apartment. Somebody above her was smoking, and the really, really bad odor was drifting down. And the bottom line is there's not a lot she can do to stop that. So it's an adverse effect, sort of indirect. Acutely, certainly marijuana can interfere with judgment, with short-term memory, and with motor coordination. And even though some individuals who smoke say, yes, I can drive safely, data shows clearly that they cannot. This was a study that was done to look at, it's a lab study, but it was looking at performance of safety in driving. It was close to 200 cannabis users. And they had a placebo, or about 6% THC, or about 13%, smoked ad libitum, which again, yes, you can have the percent of what's smoked, but again, you don't have a dose response. But it's important because what they found was there was a decrease in driving ability. Again, it's a lab study, not out on the street, but for sure, cannabis can interfere with psychomotor function, no doubt about it. Then we get into, again, acutely exacerbation of schizophrenia. What does that mean? It means that somebody who has schizophrenia, diagnosed or not, can have an exacerbation. They can have a full-blown episode of schizophrenia. It's just smoking a regular marijuana cigarette. It doesn't cause schizophrenia. Now, what about large doses? Now, I'm still talking about acute, still in the short term, like even one dose. Yes, if somebody is using THC with a really large dose, that can cause a psychosis, which we call a toxic psychosis. It's caused by, in fact, the drug. And there was a study in Europe a couple of years ago, and they looked at a number of countries, Spain, France, England, about 5 countries, a couple others, I can't remember which ones. In any event, there were kids coming into the ERs in those countries with psychosis. And what they found was there was a very, very high THC product being sold in those exact areas where those kids lived. Now, we all know we're researching, and we all know that if A is happening and B is happening, just because A and B occur at the same time does not mean A causes B. We know that. But from looking at the data, it's pretty clear that there is a connection. So acutely can cause psychosis. On a chronic level, addiction for sure, I covered that. Tolerance, I will discuss that. Tolerance can occur. And then there's issues in the respiratory system, chronic bronchitis. And then there's hyperemesis or increased vomiting. And my ER colleagues, my docs who work in the emergency rooms, have told me clearly that they have a young person coming in and they do a workup and a history and a physical and can't find anything else, but the person is really throwing up. There's a good chance that they're a chronic marijuana user. Now, this is the study involving tolerance. What they looked at were people who were using marijuana, and they did record the amount and duration of opioid use, which leads into the conclusion cannabis use associated with an increased use of opioids following surgery. What does it mean? It means that those folks who were chronic users of marijuana, post-surge, spinal fusion, so it was the same type of surgery, those folks who use chronic cannabis required more opioid pain medication. So there is a degree of tolerance that occurs, which is having a clinical impact on treatment of at least post-op pain. This happened a couple months ago, and this unfortunately person went off fell from his apartment. Who knows what happened? He was vaping. And the FDA, the Federal Drug Administration, Food and Drug Administration in the US said that there is serious respiratory toxicity. And the patients were presenting as if they had bronchial pneumonia. What the CDC said was it's probably vitamin E, which includes chest pain, shortness of breath, cough, and vitamin E acetate is their conclusion that's a probable cause of this lung injury. And this not only caused serious bronchial pneumonia, actually patients died. So they have good autopsy results as to what's happening. Continuing with that, there's other respiratory centers, emphysema, and then there's impairment of immune function. Again, I'll let you read that for a second, but it's HIV, HCV, and human T cell lymphotropic type 1 and type 2 virus. So a link between cannabis use and the immune system. A recent report in the JAMA network looking at cannabis use and coming into the hospital. Yes, there was an increased risk of hospitalization, an increased use of ICU admission of those who are using cannabis. So the point with my updated data, which I'm showing and presenting here, is there's a lot of issues showing that THC marijuana is not a completely safe product. Prenatal, that's an issue. Again, busy slide, but if you look at the highlighted part, prenatal cannabis exposure produces psychopathology in middle childhood, so it may not show up right away. Conclusion, a woman who is pregnant should not be using any form of cannabis product. This study is more recent, a couple months ago, again, in terms of my update. Prenatal cannabis use, adverse maternal health. So this is now in terms of the woman who's using it. And they have the frequency of use, as you can see. And what they're saying, greater risk of gestational hypertension, preeclampsia, which is a serious life-threatening condition during pregnancy, and also placental abruption, which basically is a miscarriage. So both for the growing embryo fetus and also for the woman, use of this product is a hazard. Another report that came out about a year ago in terms of coronary artery disease, and what this report showed is that there's about a 1/3 chance increase for coronary artery disease compared to people who do not use marijuana at all. So that's another intriguing toxic effect. This is looking at blood and urine levels, blood and urinary levels of various metals. And the cannabis plant is a scavenger of metals. When it grows out in the wild, that's what happens. The particular products are cadmium and lead. And again, these are products not grown in dispensaries. I'll show you a picture of the company that I work with. They support my research. Cadmium and lead can occur when it grows out in the wild. And they found those levels in people who were using them. What about marijuana as medicine? Again, I'll give you a second to read that. And my area is pain management. Again, going back to what I showed you already, to repeat, there are products already available for treating seizures, for nausea and vomiting from chemo, and anorexia and weight loss. So we already have those products, as I showed you earlier, just restating. My work is chronic pain, the large arrow at the bottom on the left, and there's a lot of factors that influence chronic pain. I'm looking at the biologic problem. One of the studies I did was THC over a 4-week period. This is a pilot study, and there is a need for well-controlled studies. What does that mean? What I'm doing is using specific doses. And again, a lot of studies that are published do not have that. They again will say, to repeat, well, the patients were on chronic cannabis use, and I just reported some of those to you right now. Highlighted in yellow, Doctors Galuzzi, Kate Galuzzi, Madeline Brown, and Joe Lubeck, and Jen Smith was the RN who worked with this, and I presented this a couple years ago. I do have an update with a recent patient. But basically, we're looking at folks as a 50-year spread, got to be over 25, because there's increasing information that THC can affect brain development if used younger. So got to be at least 25 and nobody over 75. Neuropathic pain for 2 or more months. In the United States, the code for getting reimbursement for chronic pain, they have to have it for 3 or more months. But one of the things I really enjoy as a medical scientist is, I can do something that doesn't have to be coded because I have support for the patient's products. So in my opinion, anybody who has neuropathic pain daily for 2 or more months, they can be in my study. And then there are some exclusion criteria. I'll stop for a second and let you look at that. So we move on. They're doing a daily pain diary, 0 to 10, and they're doing it 3 times a day, and also the amount of pain meds they take at the end of the day. I'm using the FDA-approved Delta-9 THC, which is a synthetic product. Dronabinol is a generic, Marinol is the trade name. And this is what my patients fill out on a weekly basis, how many pills they took per day. Again, their pain scores 0 to 10, morning, afternoon, and night. I start for 2 weeks on baseline. In other words, we don't give them THC, Dr. Galuzzi and I. They just record their information. It gives me an opportunity to see if they're a good recorder of information. Their time is valuable. My time is valuable. And I want to make sure that they're going to be recording pain as we asked them to do and as they signed up for. So I see them on a weekly basis. If everything's going fine, we start them on 5 milligrams at bedtime. It's POHS, by mouth at bedtime. Now, I made a change because when I said bedtime, people would get into bed and take the capsule, but they wouldn't go to sleep. We all get into bed, we read, watch TV, whatever. So if they took it when they got into bed, while they're up for an hour, that may have some effect on them. So what I tell them now is take the capsule when it's lights out time. So they may get some dreaming aspects or some minimal psychological effects, and not everybody gets this, but they take it now at lights out. And then I see them each week, and if they're okay, we can go up to 10, 15, and 20, and then it's the end of the study visit. So these are several of my patients. Patient number 1, you can see the arrows, there was a decrease in gabapentin after 6 weeks. Patient number 3 actually was pretty amazing, was using over 1,400 milligrams of gabapentin in her baseline and was 0, used none of it at the end of 6 weeks. Patient number 4, a drop of 75% in gabapentin. Now, there was an increase in Tylenol of 3-fold. And you could say, well, it's sort of a wash, but in my opinion, not really. Gabapentin is much stronger than Tylenol, so I think it still was a benefit. Patient number 5, not much of a change. Patient number 6, significant change using carbamazepine, which is a anti-seizure medicine, but is very, very good for jaw neuropathic pain, trigeminal and neuralgia pain. And she went from over 300 to none. Slight increase in diclofenac, which is like aspirin. And patient number 7, not so much of a change. So another thing that my patients are concerned about is gaining weight. And here's the results. 2 of them had a slight increase in body weight. However, 5 of my patients had a reduction. Why is that important? Well, they don't want to gain weight. Why did this happen? I believe because their pain was being relieved. I know that they were more active. They could walk their dogs. They also needed less comfort food. So it does not, even though we know about that scientific term called the munchies, when people get hungry, that doesn't necessarily have to happen. The most important thing is you look at pain scores on a 0 to 10, and weeks 1 to 2, the average was 4.9. And at the end of the 6th week, it was down to 2.7. So in my world, a drop in 2 units in the 0 to pain score is pretty substantial. This is my most recent patient. Started with a pain score of 6.8. Excuse me while I just get a drink. 6.8. And at the end, he was down to 2.7. And this happened to be a patient who told me in the middle of this, around week 4, and he had no signs of it at all, that he was basically suicidal. And if this didn't work, and so then I switched gears and said, "Do you have a plan?" And he had a plan. He had a rope, and there was pipes in his house, and he had a plan. But he said, because my pain is being relieved, I no longer feel that way. So that's my most recent updated patient. It's a pretty good one. So administration of this, we're reporting, did produce a decrease in pain scores and reduction in analgesic medication. Statistically significant? No, I don't have enough patients, but the trend is clearly there as I'm reporting. What about using it with cannabidiol, CBD, drug interactions? Yes, there is a drug interaction. The orange one is THC by itself. If we add, not we, the folks who ran this, not me, they added CBD in the same dose, increased the amount of THC. So CBD on a drug interaction was interfering with the biotransformation. The same thing for a psychoactive metabolite, 11-9, delta 9. Orange is the regular metabolite, and with CBD, you can see the significant increase. The same thing for another metabolite that's not psychoactive. So the point is that there is drug interactions that patients have to be screened. The purpose is not to review them all. They are available, and if somebody's going to be put on that, either taking it as they can recreationally or being prescribed, there has to be a search for other drugs that they may be on, because there is a potential increase in the effect. This is what I wanted to show you, Organic Remedies. This is the company that I work with. They support my research. This is their greenhouse. And as I point out, this is in the middle of it. This is not the whole thing. You double this. So this is grown in pristine conditions. And so there are absolutely no contaminants in any of their products. And in fact, state law requires that this be surveyed every so often. But yeah, that's their greenhouse. Amazing. So the marijuana that comes from this plant is illegal because the marijuana plant is illegal itself. And what I meant to say was the THC that's extracted is illegal. So I have to run an observation study. What does that mean? I can't do a clinical study because this THC comes from an illegal plant. It's a stupid law because it's the same molecule, but that's what I have to work under. So I have to run an observation study with this THC from this plant. And what it means is the patients have to be able to choose what they want. So what we propose is they start at 2.5, and I can't do a baseline because it becomes a clinical study. And again, I can't do a clinical study with an illegal drug. So it's crazy, but that's my life. Anyway, we recommend the patients start at 2.5 and then each week go up 5, 10, 15, and they can handle it. So they do, but they don't have to, and I'll show you that in a moment. 5 of my patients started at 2.5 and went up to 15. And you can see in terms of morning, they went from 4.6 down to 2.6. At noon, from 5.9 to 3.1. And at night, from 7.1 down to 3.7. So at each time frame, there was a reduction of more than 2 in pain scores. Now, because, again, and I know I'm repeating, but it's my point, because it's observation, we have to let them do what they want. So some folks went 2.5, 5, 10, and then the 4th week, they stayed with 10, which is fine. And again, if you look at the numbers, 4.9 to 1.8 morning, noon, 4.9 to 2.2, at night, 5.5 to 2.7. So if you look at the scores, you see they go up at night, which is, what you would expect. They're walking around, they're doing a lot of work, and they're more in pain. And we are able to reduce their pain at night, which means that the sleep can be better. So what do we see? An important parameter here, which we are, recording generally. They have an increase in quantity and quality of sleep. And everybody on this call knows that if your sleep is interfered with, no matter what condition you have, it's going to be worse. So these patients have really benefited by what we're doing. So I thank you for listening. I appreciate the opportunity. This is a very complex molecule.